Hello, good evening, everyone joining us for the next RAMI webinar. We are talking combined regenerative approaches to counteract tissue changes with GLP-1 therapies. Joining me this evening is the lovely Anna Baker. She is a nurse prescriber and clinical educator, and we're delighted to have her as one of our advisory contributor members of RAMI. So we are the Regenerative Aesthetic Medicine Institute, and we're all about sharing education in regenerative aesthetics. So we're just gonna let a few more people join and then we will get started. But in the meantime, it would be a good idea to find out a little bit more about you. So we're gonna pop some polls on the screen to find out a little bit about your experience using GLP-1 or relating to treating patients who've been on GLP-1 rather. So if you can first start by telling us your medical profession, doctor, dentist, nurse, a pharmacist, or other. And then we would like to know, are you noticing concerns from GLP-1 patients regarding their skin quality? So if you can answer yes or no to the next question coming up, and I imagine it's going to be 100% yes on this if you are seeing patients who have been on GLP-1s. And then next up, are you offering weight management or GLP-1 therapies to your patients? Again, just a simple yes or no answer. This is just really helpful for Anna to get a bit of a feel for who she's talking to this evening. And then finally, are you adapting your treatment plans if they are on a course of GLP-1 therapies? So you've got a 50-50 for question 2. And then this one now, are you adapting your treatment plans? Perhaps you've thought about it but haven't done it yet or aren't sure how exactly to approach it, which that's why it's perfect place this evening to learn a little bit more from Anna on the regenerative approaches you could be adopting. So there we go. Thank you so much for filling in your answers there. I'm now going to hand over to Anna, and if you're just joining us, welcome. We've got Anna Baker, clinical educator and nurse prescriber, here to talk to us about combined regenerative approaches to counteract tissue changes with GLP-1 therapies. Over to you, Anna.
Thank you, Chloe, and a very good evening to you all. And thank you guys for taking the time out of your busy clinics to join us this evening to talk about a topic that I've become increasingly interested in and something that I think we're going to be talking a lot more about and see an evolving body of evidence and experience over the next few years to come. So, as Chloe said, we're going to take a deep dive this evening into my personal approaches and favourite sort of treatment modalities, if you like, and protocols and regimens and so forth in terms of how we and our clinic team assess, tackle, and if you like, adapt the kind of treatment journeys that we've been doing historically to a growing concern that we're even seeing in our patients. Now, to Chloe's point this evening, guys, I am here very much in an independent capacity. I'm delighted to be joining a wonderful team of friends and colleagues as one of the newly appointed RAMI advisory contributors. So thank you guys so much for having me. But alongside that, like many of us in medical aesthetics, I'm very delighted and a very busy lady, I will say, in terms of wearing different hats and enjoy a variety of different clinical roles. But as I say, in terms of the brands, the technologies, and certainly the clinical results that I'm going to share with you this evening, naturally in our practice, we will all have our preferred brands, our preferred technologies, approaches. Some are off-label, some are very much sort of customized to the kinds of concerns that we're seeing. And I'm very happy this evening to share those experiences with you. But I will say that all the brands that I'll talk about are ones that we use on a regular basis at the bedside with our patients. And certainly I'm not here in a commercial capacity to really sort of promote those overtly to this evening, but really just to speak from our honest experience. Now, to sort of step back a little bit and talk briefly about the demographic area that we practice in our clinic, and also give some context around my interest, I suppose, and our growing collective interest as a clinic team in terms of this particular area. Now, I'll be honest, as a clinic team, this subspecialty of treatment in terms of weight loss, even bariatric care, is not something as a clinic team, I'll be honest, that we have a huge amount of experience in. We're not involved in actually assessing patients or administering these therapies at the bedside. this area around the growing concern of the tissue changes that we've witnessed as a quite a rapid growing concern when we look back at our patient data and our audits over the last 12 months. And these are patients that we have which are actually receiving GLP-1 therapies, often under the medical care of other practitioners or other allied practitioners that we've referred them to. But nonetheless, they look to us with the trust that they've been on a patient journey with us for a long time to guide them and support them, often in unexpected or very rapid changes that they're seeing on their weight loss journey when they actually start these GLP-1 therapies. So, as I say, it's sort of been an unexpected journey for us, if you like. We're learning all the time. I've got lots of sort of current evidence and some of the most interesting papers that I can find that are really unpacking what we think is happening at all these different sort of structural changes in the skin, and certainly some experience from our patient group in terms of the case studies and the kind of treatments that we're really finding in our experience seem to be hitting the mark at the moment for these types of tissue changes. So again, for context, in terms of where I'm based and where our clinic team is based, we have a practice that's based in East Grinstead in West Sussex. We have, I'd say, quite a broad patient population of different ages, men to women. And historically, we've delivered a variety of different types of skin treatments. We do a huge amount with skin quality. We do see and treat a lot of photo damage, offer a variety of different energy-based injectable and skin treatments and technologies, see a lot of different types of menopausal skin concerns. But I would say in terms of what we see historically, the GLP-1, if you like, subset and cohort aside, we have a patient group often with very challenging types of existing skin concerns, and what I would say more of a very corrective population of patients, almost now with another layer of concern in terms of these rapid tissue changes that they're seeing if they are starting their GLP-1 journey. We do have quite a large team of individuals in our practice. We are a nurse-led business, but we do also have an osteopath, dermatologist, plastic surgeon, and a very close sort of working arrangement with a number of different colleagues within our demographic as well. And I think when we think about this area of GLP-1 therapy, which, as I said, my thoughts on this topic is it is very specialised, whatever sort of way you're coming at it, particularly if you're administering these treatments. And that MDT and holistic approach is very, very important. So before we dive into sort of the more bedside, if you like, and grassroots approach of how we have chosen to tackle these types of skin changes and skin problems, we're just going to kind of step back and look at the mechanisms that we think we know and think we understand in terms of what's driving these tissue changes with GLP-1 therapies. And there are a lot of questions here in terms of what's happening in the longer term, as well as actually what's happening in the shorter term. Are they dose dependent? Are there variances in terms of male to female, different types of drugs within these sort of subtle nuances between the GIPs to the GLP-1 RAs? There's an awful lot we don't know. So I think these conversations like we're having this evening, shared experience, questioning is really, really important because there's going to be so much more to come on this, I believe, at least over the next few years. We're then going to translate that into, as I said, more of a practical approach in terms of how we choose to tackle this. But again, as Chloe said, it would be really nice to hear everyone's thoughts, questions, perhaps different approaches, because as I say, in terms of what I'm going to showcase this evening, we don't have every piece of kit in our clinic. We specialise in, as I say, we sort of understand the technologies that we have very, very well, and we have a high level of expertise with them. But I know for sure they're not exhaustive. There are many different approaches, views and opinions out there about what could be used instead of or as well as. So, I would love to hear everybody's thoughts on that as well this evening. I have a very, very private group of patients. Well, we do, I should say, as a collective and as a patient group. So I would just appreciate everybody's discretion this evening. I'm very happy to share and talk about these cases with you, but I really, really would be very unhappy if I see any of these slides or patient images, particularly landing up on social media pages. As I said, please respect the privacy of our patients, because as I said, we're not able to actually show these results to you. What I'm going to say to you this evening is pretty meaningless. So thank you all very much for showing the respect to our patients in that regard. So looking at things broadly now, as I said, we're going to kind of look at some of the current evidence, some of the best papers that I can find, which are referenced and free to download if any of you would like to take a deeper dive into this after this evening. But what we believe is happening here in terms of patients on the GLP-1 therapy, irrespective of dose and irrespective of age and BMI, is that there seems to be a really complex metabolic interplay of these four factors, but still some intricate questions around things like the possible loss of muscle and connective tissue. And I'm going to unpack that in a bit more detail shortly. But we believe that there is a direct effect on adipose-derived stem cells and ultimately a decrease in terms of adipose tissue volume. So part of the deflation is happening at that level. That's also having an impact in terms of patient skin quality and overall elasticity. So we are also seeing as well a decline in density in collagen fibers. So if you like, the protein load in the skin is being hit quite hard in terms of the receptors that these drugs are targeting. And as I said, there is also this potential question hanging around whether in fact there is also some depletion or if in fact actual muscle atrophy that's occurring as well. But the literature that I've read seems to be very conflicting in terms of whether that is the case or whether it's actually the contrary. So we'll dive into that in a little bit more detail and respectively look at each one of those factors and then kind of consider which treatment would be best in terms of targeting those particular changes from these drugs. Now, as I said, it does seem to be an area that is of great interest to many clinicians out there of all different clinical backgrounds, because I think from what I'm seeing, this is a global phenomenon and almost a pandemic in terms of the concerns that we're seeing from patients, as I said, a variety of ages, of different drug doses, whether they're microdosing or on a full therapeutic dose, actually for obesity and better glycemic control. The skin changes and concerns reported are sort of out there and being reported weekly in the literature. What I would say, guys, if you're looking for a paper, or one of the best ones that I can find that unpacks these changes in a lot of detail that's pretty straightforward and I would say easy to understand, just where I'm hovering my arrow key to here on the right-hand side, this paper from 2024 from Sabrina Fabi and a number of other colleagues is an absolutely brilliant read that talks about all of the different structural changes and the possible mechanisms behind them, but also flags up the big gaps in our knowledge and areas where sort of collectively as a community, we need to sort of unpack a bit more and do more research on. But if we think about one of the biggest changes initially, we believe that there are lots of different changes happening that are affecting the regenerative capacity, if you like, of the good fat or the white adipose tissue in our body. Now, white adipose tissue comprises an overall sort of 10 to 20% of total body weight in lean adults. And contrary probably to what many of us think, fat, as it were, if I say that more broadly and generically, is not necessarily the enemy and something to be feared in the way we think it is, because different types of fat, and white adipose tissue and dermal white adipose tissue being one of these components, has so many important metabolic and paracrine signaling mechanisms, but is also home to the source of adipose-derived stem cells, which have so many important regenerative and metabolic roles in terms of the immune health and immune functions within the skin. Adipocyte dermal stem cells as well do also secrete so many important different types of regenerative sort of cofactors, things like hormones, cytokines, that are really important not only in skin health, barrier function, but in skin rejuvenation, but also the key in terms of the actual integrity and the structural health of the skin, as we said, at a metabolic level as well. But the data does seem to indicate that there is a positive correlation between the dermal white adipose tissue volume overall and BMI, with adipose tissue actually having a very important protective effect against skin aging. Again, to reinforce my point around the fact that fat necessarily isn't the biggest evil necessarily. Controversial topic, I know, but it isn't the fear factor that we think it is necessarily, because it has so many important roles to play almost at a regenerative level within the tissue. Now, I think it's one of the concerns that we have around the GLP-1 RAs or even the GIP factors of these class of drugs is that these types of drugs act very differently on adipocyte stem cells compared to, if you like, more mature stem cells in the tissue. And we believe that these drugs actually are non-selective in terms of the types of stem cells that they're targeting, and actually almost reducing the regenerative effect of what these adipocyte stem cells can do in terms of the skin. So the effect of these drugs, thinking above and beyond the weight loss implications, we think they're actually modulating adipose tissue and ultimately sort of affecting skin health, with a potential knock-on effect, we think, in terms of muscle mass. Now, something else that I was quite surprised to read about, and again, this was new information to me until quite recently. And again, to sort of draw everyone's attention back to this paper that I mentioned before, it really does give us the most sort of interesting overview of what we think is happening, because it's also believed, broadly speaking, that the GLP-1 RA drug class is also indirectly reducing the dermal estrogen production in skin as well. Now, I think those of us that are treating our patients who have menopausal skin concerns, or those of you that are involved in wellness and indeed women's health, will be very well versed on the important role of estrogen in terms of skin integrity and skin barrier protection. But actually, because this drug class are actually reducing the density, if you like, of the dermal white adipose tissue, and therefore almost inhibiting the protective, if you like, and regenerative effect of what those stem cells are doing, this ultimately has a bigger knock-on effect in terms of reducing the production of dermal estrogen and the subsequent growth factors. Believe it or not, if you like, the byproduct of that, further down sort of this negative cascade, I suppose, or this more sort of degenerative cascade, can mean that it can indirectly increase levels of circulating testosterone and ultimately sort of drive home or reduce that fat loss even further, which again may not necessarily be the worst thing if we are targeting a high BMI, but it could potentially be quite detrimental for patients who may be microdosing for other types of health concerns or more off-label indications for GLP-1. Now, to go back to the point I mentioned before about this potential knock-on effect of what is believed, or as I say, still quite controversial in literature about whether there is or isn't some sort of knock-on effect in terms of muscle mass or loss of muscle density, if you like, skeletal muscle mass, or even a degree of muscle atrophy. The literature is very much 50-50 and imbalanced and not really swinging towards one opinion over the other. Some studies that are human, rat, murine based seem to imply that overall there is a better proportion in terms of reduction overall in terms of bad fat, and an increase overall, almost a protective benefit in terms of skeletal muscle mass. Whereas other literature actually says that it is disproportionate and it swings the other way. There is in fact muscle atrophy, decrease in skeletal muscle mass, and actually an increase in fat overall. So this is an area I think we all need to sort of be very vigilant on. I know certainly from speaking to many colleagues who do specialise in this area and are working within weight loss environments or bariatric trained, I'm well aware that the good advice and practice around these types of therapies at any dose for GLP-1 centres around, increase in terms of protein intake and also sort of increasing the amount of, if you like, weight bearing, lifting weights and so forth, to certainly build that protein and ultimately try to improve the quality around the muscle mass and the tissue as well. But it's interesting because this at the moment seems to be a real question that's hanging over these types of drugs, but there is a real disconnect currently in terms of what we think is happening here in terms of muscle mass. And this seems to be across all of the drugs, whether it's Ozempic, semaglutide, Mounjaro, there is inconsistency amongst all of them. And again, I think a bigger challenge that I found in trying to read the literature is that these drugs are not necessarily wholly comparable in terms of their effects either, which adds another layer of confusion, I think, in terms of trying to get true head-to-head studies, particularly when we're looking at muscle mass. So I guess really my message here is to watch this space. We seem to understand what's happening in terms of collagen. We can agree there's depletion. There is loss of protein. These receptors are non-specific, or I should say the drugs are non-specific in terms of targeting the GLP-1 receptors in skin, certainly in good fat as well as bad fat, and potentially in muscle as well. So now we can understand that there are three things, if you like, or three key layers within the tissue that are being significantly impacted and often rapidly impacted in terms of this overall deflation, which I think is a word that I keep hearing a lot from patients, in different sort of literature reviews, but it's rapid. And this is in addition to maybe a patient that may already have menopausal skin concerns, a patient that may already have acne scarring, active acne. These deeper structural changes are happening and coexisting alongside almost another sort of layer of concern that we need to think about addressing. So I'm going to kind of take this almost from the top down and think about, if you like, the most sort of superficial, overarching, broad spectrum therapies that we offer that are diverse, very well tolerated, very good price point for patients, don't really compete with anything, and ultimately complement all our other offerings. Because I think a treatment like LED phototherapy may sound far too simplistic in terms of what we're trying to reverse in terms of this rapid tissue deflation. But ultimately, the key theme that we've seen here, if anything, even with the estrogen decline in our female patients particularly, is the fact that the skin barrier is fragile. There is probably going to be a high level of inflammation in the tissue. And LED phototherapy is something we are huge fans of in our clinic. It's an enormously popular treatment. Critical factor being the right dose of light at the right wavelength over the right sort of delivery time, if you like. And these are very well published, very well accepted and acknowledged wavelengths, but we are light sensitive beings. There's a huge amount of conversation about the mitochondrial elements around aging at the moment. Again, really fits in nicely with the regenerative dialogue. It is a hot topic, but LED therapy, I feel, is a great place to start, whether it's on its own, standalone, or in combination. We're finding this to be an enormously popular treatment in standalone, and in combination, something that we've used for many, many years. So we are big fans, and I would wholeheartedly advocate that for these types of patients. Now, thinking about other individuals who may be noticing that sort of tissue laxity, not so conscious of like the adipocyte changes and more, should I say, sagging, but sort of more the crepiness, the loss of elasticity, that protein degradation that these drugs are so closely associated with. A treatment like radiofrequency, we find to be an enormously popular treatment in as far as, dare I say, more of a lunchtime approach. It's often an exceptional price point. There are lots of different and excellent types of technologies out there. And again, I'm not here to certainly advocate one over another. I'm sure many of you this evening are offering a form of, not sort of necessarily fractionated, but a non-fractionated RF in your clinic. It is absolutely excellent in terms of that very gentle thermal heating to the tissue. Patients can literally return back to work. But ultimately, when we know that protein is obviously being denatured, that elasticity and collagen is being hit really hard with these therapies. It's bipolar, monopolar. Again, there are so many different types of devices out there, but it is a well-recognized, established, and evidence-based treatment, which again suits many, many individuals. And I'm thinking more about individuals here who may not necessarily be able to go the extra mile and have something with any element of downtime. Patients who may be sort of working within a very specific budget in terms of their treatment journey with you. So for us, radiofrequency, again, is something that so many of our patients, and even us as business owners, really advocate and utilize on a regular basis all year round. We don't really have to think about seasonal considerations in terms of, dare I say, staying out the sun or being cautious in terms of certain times of year. So then if we think about working a little bit more deeply, dare I say, and trying to target some of the slightly deeper changes that we believe are happening in terms of these changes around the GLP-1 therapies. I'm sure I'm preaching to the converted, and I'm sure many of you this evening are huge fans and advocates of different types of polynucleotide injectables in your practice. And for us, these have become a very firm staple, not just in patients with these types of complex tissue changes and rapid tissue changes with GLP-1 therapy, but indeed in patients with a huge variety of different types of anti-aging concern on the face, neck, and body. Because again, we consider, or lots of the literature talks about GLP-1 therapies being really centered around the concerns that patients have on more visible areas like their face and neck. But these are systemic therapies that mean that, that laxity, that GLP-1 depletion, and those receptors are throughout our body and not just on visible areas like the face and neck. So for us, when we're thinking about treating these types of concerns, it's important for us that we utilize or we find technologies that are broad in terms of their anatomical indication, that they're not just necessarily indicated and used for the face and neck, but that we can expand those indications onto the body as well. And to my point before, GLP-1 therapy or otherwise, we see and treat an awful lot of hyperpigmentation and photo damage in our skin with patients on these therapies or without. So these types of technologies for us have revolutionized our practice in terms of not only the dermal thickening, the protein regeneration, but also the skin evening benefit and that lasting regenerative effect that we find from experience often gets better and better 5, 6, 7, and 8 months beyond, particularly if we utilize more hybrid treatments that almost have an element of a non-crystalline HA. We can actually replenish and feed that skin that's often very depleted, thirsty. Patients are feeling, as I said, they've got that Ozempic look to them, that deflation, these types of technologies we find are so multitasking and diverse in terms of their regenerative effect that we actually notice that dermal thickening happening often very quickly. Like many things in medicine, we know that these types of technologies, whether it's polynucleotide or PDRN, the higher the dose, like many technologies, often the more effective they are. So much of what we do in medicine is dose dependent. And I would say the dosing around this type of treatment often is no exception to that. So typically, working with a higher concentration here, we often see a more profound and sometimes a more rapid regenerative effect in the tissue, which I think is really nice and gratifying for patients, as I say, who are on these GLP-1 therapies, who are noticing this rapid decline really quickly, particularly around that sort of mid-malar and buccal area. It's great to be able to replenish and try and turn around those concerns relatively quickly if we can. And again, just for those of you maybe that are not so aware of polynucleotides, I know that these are enormously popular treatments. There's a huge amount of dialogue and interest around these technologies. But for us, they tick so many boxes, as I'm sure they do for you guys in your practice, not only, as I said, on the face and the neck, but on areas in the body as well, particularly for us in terms of that reduction in pigmentation, that anti-inflammatory effect, which we know is a key factor or a key byproduct of what's happening with GLP-1, targeting that fibroblast activity and therefore seeing that improvement in terms of collagen and elastin and boosting that protein in the skin. Many of them we know are not all the same. And this is just a short salient note, I think, for all of us to do our due diligence in terms of these technologies and remind ourselves that whilst they are highly respected, I said very highly regarded and long established regenerative technology, it would be naive of us, and I think complacent to consider these all to be in the same category. Sometimes the origin of the raw material can differ, the manufacturing processes are not necessarily comparable. So whilst we acknowledge that broadly speaking, this category is exceptional, I believe, in terms of what it can deliver in terms of all these diverse concerns. And I think it's very well placed to treat this variety of different changes that we're seeing with patients with these GLP-1 concerns. It's important for us, again, to always be working within our scope of competence, sourcing product from recognised manufacturers and, as I say, respective manufacturers, and just ensuring that we do our due diligence around the technologies that we're using. Now, thinking about working a little bit more deeply now, and again, coming back to considering and addressing those types of changes that we're seeing within the adipose layers. As I said, this is one of the key layers, I think, and one of the key structural changes that I think can be most impacted in terms of the patients that we've seen on a variety of doses with GLP-1s. Now, Profilo Structura, we found to be a really useful toolkit to have in our kit, not specifically just for these types of patients specifically, but ultimately because I would say it's such a unique injectable in terms of what it's doing, targeting, or if you sort restoring or regenerating the adipocyte cells or the pre-adipocyte stem cells within the fatty layer. This treatment gives, what I've noticed and what I've seen, a very sort of gentle and soft repositioning and almost a strengthening effect to the superficial fat pads in the face. And it is I would say, a fairly rudimentary and straightforward cannula approach to administer. Again, can complement all other technologies and treatments that I believe, that our patients are offering and should ideally be administered over a course of 2 treatments with a month interval between them. But similar to its sort of first generation counterpart, this is a 90 milligram concentration as opposed to a 64 milligram concentration in a 2 ml syringe. But again, utilizes the same patented NICO technology. So this is a thermally bonded hybrid utilizing different molecular weights. But again, specifically is designed to target those adipocyte age-related changes that are happening independently and intrinsically, irrespective of whether patients are noticing and sort of experiencing those changes on the GLP-1 therapies. But I think particularly for patients, as I say, going back to the GLP-1 or the place particularly, I think for this, as we found in our experience, for targeting, those more sort of like real sort of not sagging as such, but patients feeling really quite deflated from the GLP-1 changes. This treatment, I believe, if patients are happy to go on more of a journey and achieve a gradual softening over a period of 2 months, as opposed to something more instant, again, case by case, of course. For us, we find that this treatment works very, very nicely for this indication and just gives that soft, gentle repositioning, but again, can be combined with any other treatments again that our patients are having. So, as I say, in that point, we're just really looking around sort of standalone options that we find work well for us. But something else that has been a surprise to us as a clinic team in terms of the types of concerns that we've been seeing specifically with our patients in GLP-1 is almost an increase in their concern around developing cellulite, even cellulite perhaps that even wasn't that noticeable before, but it seems to be sort of a real issue, particularly those who perhaps had a higher BMI and were utilising GLP-1 RAs at higher therapeutic doses and noticed that sort of more rapid decline in weight, have noticed accordingly not just a deflation in tissue, but also worsening areas of cellulite as well. And again, I think, we're into new territory here, and I'm not saying that any of us really have the answer at the moment as to why this is happening. But we have found ourselves in new territory now, with an increasing sort of demand and expression of interest from our patients around what can we offer for cellulite? Because historically for us as a clinic, I was deeply cynical, if I'm honest, about treatments for cellulite, was never really convinced, if I'm honest, that anything worked. And it is, let's be honest, historically a very poorly understood condition that was never really associated with someone's weight or BMI. It affects, to the best of my knowledge, sort of 80 to 90% of female patients of a variety of shapes and sizes, but has a far more of a predilection for women than men. And we think at the moment, GLP-1 RA indications or concerns aside, we believe that there are 3 reasons for why cellulite exists more in a female population and seems to worsen more in classes of patients who've had that rapid deflation from GLP-1. So we think certainly there are sex-related differences. There are something called fibroreceptor that we have in our tissue. Men have them and women have them. And I'm thinking around the sort of the trochanteric area, around the sort of the thigh and the buttock. But these fibroreceptae between men and women are sort of, if you like, structured in a very different way. Women tend to have a very vertical arrangement with fat lobules that can sort of pass more easily. They're bigger in size generally than our male counterparts, and they can often pass more easily to the surface and give rise to that sort of classic dimpling or orange peel effect that we see on the skin. But men, by point of difference, actually the fibroreceptor are a little bit more at a 45-degree angle, and they're far more sort of crisscrossed in their arrangement. So they're sort of more structurally intact in terms of keeping these fat lobules that are typically smaller than women, again, irrespective of BMI and weight overall. So this is why we generally don't really see cellulite in men. But it's an interesting question around what's happening around GLP-1 as well, because as I said, for the first time ever in our practice, particularly in the last 8 months, this has been a massive rise in concern in its own right in patients who've had this rapid weight loss. So it's something really that has kind of forced us to look at what's actually out there. What can we think about bringing on board to treat these types of concerns? And I think particularly often this type of concern, I would say, really rears its head once we get more towards the summer months, of course. So to share some very early experiences, I will say, full disclosure, on an injectable that we've been working with for the last 3 months now. This is a very interesting technology that seems to target a number of the possible causes to cellulite. But what's interesting is these case studies that I'm showing you are patients on GLP-1 treatments. Now, typically, when you think about what's happening with those receptors being hit hard and targeted in terms of like their reduced regenerative potential, I think it's interesting that there seems to be something here that can still offset and work against what we're seeing in terms of these detrimental effects of the receptors that the GLP-1 therapies are still targeting. And also this particular formulation seems to be very effective at sort of conditioning the extracellular matrix, and also boosting collagen as well. It does contain calcium ascorbate, so it's got a very high concentration of a stabilized form of vitamin C, alongside a number of other ingredients as well. But we've been very impressed to date with what we've been seeing, because this lady in particular has been on a high therapeutic dose for some time for GLP-1 and has gone right down to a microdose now, but was very, very concerned about the changes in tissue quality, the sudden, as she said, appearance of cellulite, even though she's exercising, she's doing weights, she's really very committed to, ensuring that she can get the best results as possible, not only from the therapy, but also from any treatments that we're offering. So it's very gratifying to see that just after sort of, anywhere from 2 to 3 treatments, what we thought was not achievable is achievable. And as I say, it's gratifying because at the moment we're only sort of talking about standalone treatments here. I think we can all sort of acknowledge as a sector that given that what we know about GLP-1 so far is that there isn't just one layer or one subset of tissue or structures in the skin that's being affected. And I think as a community and as a collective of medical aesthetic professionals, I think there is sort of a wide understanding and agreement that if we are going to sort of go on a long-term journey with our patients, whether they're on GLP-1 therapy or not, you know, there is always a place for a different combination approach for our patients, depending on what their concern is, depending on the time of year, and adapting that as they go through life, if you like, and also their long-term journey with us as well. And I think, we have a variety of different treatments, as I mentioned in clinic. We do a lot of energy-based work. We have a very nice cross-referral and we share a patient group, but we also do a lot of different injectable treatments as well. But as I say, we do a lot. My bread and butter is very centered around skin quality. So I'm particularly interested in terms of what we can do to step up or build on or adapt what we've been doing already in terms of, sort of still treating the deeper structural changes and the intrinsic aging that's still happening, but sort of how we're then compounding it and what else we're looking at that's either targeted to improving these GLP-1 therapies, but also really amplifying these treatment outcomes. So it's good because it's pushing us and it's making us think about what we need to do next and where we need to take our patients. So here's a great example because, as I mentioned, a corrective population group, dare I say, we do have, if I can say without causing any offence, a very mature set of patients. I think the eldest patient I've got is 90 and lives a better life than I do, I will say. But ultimately, this is the degree of photo damage that we see, which I think in this day and age is quite shocking. But nonetheless, we're looking at a lifetime's worth of DNA damage here. This is not recent damage, but ultimately, there's multiple changes to address across all layers of tissue, compounded by the fact that this lady was on a high therapeutic dose with GLP-1 as well. So we used a biostimulator. She had a course of polynucleotides. I'll talk about this topical in a second because it's been a fantastic adjunct for us for these types of tissue changes. And she also had a course of non-cross-linked skin boosters around the perineal region and around more targeted areas where we know other treatments, I would say, like more line relaxing treatments, have very limited effect when really we need to be working in a more targeted way to actually treat the skin at the root cause. So this is where she is so far with us on our journey. As I say, 79 years old, so we need to be realistic about the time frame that we're going to see results, not just the fact that some of these receptors in her skin have been shut down and switched off or may not be as quick to regenerate because of the systemic therapy she's been on. But again, it really underscores why we need to be thinking about, or sort of, not just changing our approach historically, but really sort of increasing and broadening the scope of how we've been combining our more traditional approaches for these more complex needs or sort of more stubborn skin needs that our patients now have. But taking that similar approach in vain in looking at a younger lady here, 51-year-old female, Profilo and other sort of skin boosters and bioremodeling skin treatments historically have been a very popular treatment for us, not least because of their diversity, but their safety profile. And again, their utility and the synergy that they can complement anything else that we're offering in practice. So combining that again, looking at as more of a sort of a multi-layered and structured approach, dermal filler, topical skincare, more targeted skin booster and LED treatments and Profilo, we can transform these tissue changes from these patients, as I say, that are noticing that rapid decline, but ultimately it still means that we're keeping them on that long-term journey. Now, to my point before, when I mentioned that I think a lot of the literature that I'm reading at the moment seems to get very caught up in the types of skin changes that patients have being centered around their face and neck when they're on GLP-1 therapies. But that doesn't translate to what I'm seeing in practice. I think it's only really giving us half of the story because those effects of those drugs and those receptors are, throughout our patients' bodies and throughout the different layers in the skin. And you can see the deflation that this lady had, again, from rapid weight loss on a high therapeutic dose and is now on maintenance treatment. But that type of deflation is not easy to treat, particularly of a lady, sort of 50 to 60s and above with that estrogen decline and that potential reduced capacity. But again, going back to the point I was making before about, dose-dependent outcomes giving us generally a higher or more powerful regenerative effect. utilising a 50 milligram PDRN concentration, 2 mils. This lady actually had 4 mils per leg, I will say. Again, larger surface area, high degree of tissue laxity, and a more targeted topical that's designed also to work in tandem with these treatments and also thicken and build protein in the tissue very quickly. It does mean that we do have these treatments up our sleeve to be able to target these changes, albeit, we're using them not just at high concentration, but in terms of high volume as well. But this, I believe, is where we need to go to often improve these types of changes, particularly when we are working and treating patients, dare I say, who may be of a certain age, because we know that that regenerative response to treatment generally reduces with age anyway, never mind where they've been on GLP-1 therapies for some time. Now, I'm sure many of you guys, or those of you at least who have an energy-based toolbox in your clinics, may be offering some form of fractional radio frequency. And again, there are lots of different types of technologies out there. And to my point before, I'm certainly not here this evening to commercially advocate one platform over another. Everyone has their preferences. And I think we're really spoilt for choice in terms of the quality of the energy-based offerings that are out there now. It's a minefield, let's be honest. But we've worked with Morpheus 8 for a long time. We've had our system for about 7 years, and we put it to good use. But what I will say from experience is, whilst the literature advocates, and we would recommend in our experience, it is a great offering for patients with these types of GLP-1 skin changes. But with that rapid deflation in skin quality and that thinness to the tissue, we find that acclimatizing, or if you like, priming the tissue beforehand to build protein, really sort of refine and strengthen the barrier of the skin and the overall skin integrity before coming in with a fractional energy-based approach, actually yields a much better outcome. Because typically, again, to my point I made right at the start of this evening when I was talking about LED almost as an entry-level treatment, reason being because typically in my experience, I see skin that's very fragile, not just the laxity, not just depleted in protein, but it's fragile and it's very prone to irritation. So going in too heavy too soon with something like fractional, particularly on an area like the neck, it's not something that we would recommend. There is always a place for it potentially, but the thicker and the stronger and the better the skin integrity, which is why we went initially with a course of polynucleotides first, even a more targeted way to actually improve these horizontal lines here. Because an area like the neck where the tissue is so much thinner and more fragile, naturally with these types of treatments, these GLP-1 therapies, it is an area I think where we notice that patients get very concerned about, because generally the skin is so fragile there from the outset. But fractional RF, again, in patients who are good candidates, can be combined very effectively with treatments like dermal filler at a recommended time interval. I'm not somebody that likes to throw the kitchen sink at patients, and I think there's a time and a place for combining a lot of different modalities together, but allowing that tissue time to respond, allowing those cells time to wake up before we come in and stimulate them in a different way, or actually sort of come in and work at a different layer in the tissue, but even in the same area, for example. And Profilo, again, we find to be very effective. This lady, again, had been on a high therapeutic dose and was just really weaning herself off slowly. But you can see that high level of inflammation, that fragility in the skin. That skin's depleted, it's dry, it's got sort of a lot of fine lines and laxity. So I do feel that there is a place to combine these different modalities that are really targeting these types of changes that our patients have. As I say, not just the intrinsic aging that's happening irrespective, but also what's happening as a result of that rapid depletion. And as I said, an area like the neck, again, our lady here with a high BMI, notice that submental heaviness and that creasing. But after a course of polynucleotides and a targeted topical, we can achieve some really rapid improvements in terms of restoring that skin firmness and almost eradicating. Over time, I will say, these are not results that are born overnight. I would be skeptical if anything was to the contrary, but we can deliver some really outstanding results in a fairly short time frame in respect of the type of challenges that our patients are going through with these types of therapies. And again, I'm labouring the point about the neck here, because not only I think is it probably one of the most historically challenging areas I think we treated in medical aesthetics, but again, it's highly prone, I think, to the loss of protein and the depletion tissue. From what we've seen, again, I'm really only speaking from my experience here, but it is one of the areas I think, apart from areas on the body, where patients notice the changes in their tissue quality very rapidly, and almost a bit of a predisposition as well to high levels of inflammation. And where there's inflammation, we know that there is a high risk of hyperpigmentation. One of the other pieces of electrical kit, or energy-based technology, I should say, that we find to be particularly useful for this subset of patients is we have an ND-YAG headpiece on one of our lasers, one of our Linton lasers. And this 1064 handpiece is useful for several reasons, because we can use it broadly and diversely across a very wide range of skin types. And also, it's inherently gentle. So, there is a lot of literature and evidence behind it to support its ability to treat lots of different vascular malformations on the face and areas on the body, again, broadly across all skin types. But also, because of its inherent gentleness, it's actually a pretty pleasant treatment for patients to receive. So we don't typically expect there to be downtime, but that wavelength is very powerful in terms of what it can gently treat. And here you can see that again with some preconditioning with polynucleotides, again, to broadly improve and target that existing inflammation, boost the collagen and reduce the hyperpigmentation, strengthens that skin even more to get a nice result from, I think this lady only had 2 sessions of ND-YAG to get that level of tissue tightening without the risk of any downtime. Again, obviously working within the appropriate treatment settings, of course. None of these treatments are risk-free. But again, working within our scope of competence, this particular wavelength, as I said, is long recognised because of its broad range of benefits. And as I said, in terms of its diversity for what we can use it in as well. So for us, irrespective of our GLP-1 cohort of patients, this is a very hard-working handpiece for us in clinic as well. I've had it, and it's a particularly lovely treatment. Now, to finish up, guys, and thinking about sort of what we can do, I suppose, never to underestimate what we can do with the right type of targeted topical, because whilst we acknowledge that combining different modalities is collectively targeting these different structural changes that we know about already in terms of what this GLP-1 drug class is doing, our philosophy before we sort of branched into tweaking our protocols and, sort of revisiting our treatment plans and things for patients is that ideally, patients should be supplementing any type of treatment outcome or journey with us collectively with a form of bespoke topical skincare that, best case scenario would be adapted and modified and tweaked throughout each season and therefore long term. Ideally, to prep the skin before treatment, to get the best results, and also to maintain the best outcomes long term. And also that replenishment as well, speaking a little bit more commercially. But ultimately, this particular topical here has been something that, as an accidental discovery for us as a clinic, has been a real game changer, not just for this group of patients, but ultimately for almost all of our patients, I will say, because it has a proprietary blend in it that was designed specifically to rapidly turn around this sort of dramatic deflation that patients were very concerned with, improve the areas of hyperpigmentation, but also boost protein and collagen production in the skin and reduce inflammation, which we've seen it do time and time and time again. And as I say, the proof's in the pudding here. And I think one of the most hardworking and impressive areas that I've seen, and we published these case studies because we were genuinely so impressed as a clinic, on patients. And as I say, it's a 79-year-old female who's had no other sort of concurrent treatments. This was the same lady that I showed you before who'd had the combined approach to her face, but the neck was a real concern for her. So we put this product to the test on her as a standalone, and she's still, unsurprisingly, still on it to this day. And 7 months later, we've been truly astonished in terms of what it's done. But as I say, consistently, we've seen the same thing time and time again in all our patients. But it's a critical one, again, that's nice to be able to bring to the narrative of patients on these GLP-1 therapies to say, there are targeted topicals out there, very specific to these concerns that will rapidly, not necessarily turn around or mitigate, but rapidly restore the protein, reduce the inflammation, hydrate the skin, without irritation and don't mean are not there necessarily to be used in place of something else. Our ethos is that we don't want anything competing. It's all got to work together. We need that cohesivity in terms of our treatment offering. Now, what's interesting, and I want to end on a slightly more controversial note here, feeling that all I've done is talk about the negative effects of what GLP-1 therapies are doing, or as much as we know at the moment. And to my point, there's an awful lot we don't know. But what we believe is happening again, and there's such a dichotomy here, in that, and this is just a small snapshot of the studies I've found. There are many, many more out there, and everything I've tried to refer to should be easy to access as well. Very happy to share the references after this evening. But we believe that, or the evidence seems to suggest that there is emerging benefit for this class of drug, dose to be determined, at reducing or improving certain inflammatory skin conditions. I'm going to leave it at that, only because at the moment the mechanism behind that isn't understood. But there are some very interesting anecdotal and observational case reports that are cropping up in the literature. And I believe I'm also right in saying, in terms of future interesting directions for where this drug class is going to go, again, at a dose to be determined. I believe that Manjaro, but there may be others, is expected to be licensed for polycystic ovaries because of its excellent effects in terms of glycemic control, and therefore being able to sort of, in principle, target one of the key root causes of polycystic ovaries, which, as we know, is insulin resistance, as the sort of main protagonist in terms of high levels of androgen, hirsutism, and all those systemic symptoms that we see. We treat a lot of patients with PCOS from the laser hair removal side in clinic. So we're very interested to see where that goes as well. So really to sort of bring all of that together and to sum up, we know, well, what we do know is that we know enough to say that these multifaceted changes in different structural layers in the tissue ultimately do support the need for, and certainly the place for, combined approaches. I've really only shared the ones that we found as a team seem to be working well for us at the moment. But again, this is a fluid process for all of us. That's not to say that this approach will be the same, or the same protocols, the same algorithms that I would share if I did this again in 6 months. I'd like to think that we're constantly learning from each other, learning from shared experiences, conferences, papers, case studies, so that we can all ensure that we go on the best journey we can and support our patients on this very specialist journey, because the evidence is emerging. We need to stay vigilant, stay within our field of competence. It's a specialist area in medicine, and maintaining our current knowledge, I would argue, is super important, and something that I'm very passionate about. So I think everyone that's taken the time to join us this evening, again, I think actions speak louder than words, and you are invested in your education the way that I am. And, it needs to come back to the bedside in terms of educating our patients as well. And the results that I've shown you in those patient protocols, we take the time to rationalise and justify and explain to patients when, we are sort of wading into unknown territory. And are they happy to try this when we don't necessarily have the evidence or the license to back it up? And that transparency, I think, is super important. But to Chloe's point earlier this evening, this is our experience only. And I would love to hear your thoughts, not necessarily this evening. If you don't want to sort of ask any questions now, there's no compulsion to. But by all means, do feel free to email me, because I would very happily talk through any of those cases in more detail. And yeah, just take any questions. And if I don't know the answer, generally I know somebody that does.
Thank you so much, Anna. That was an excellent and very comprehensive presentation this evening. If you've got any questions, then you can pop them in the chat at the bottom of the screen. I've just got one question, Anna. How important is the timing when you're introducing regenerative treatments alongside patients' weight loss?
What a question, Chloe. I mean, and I'm just speaking really, thinking on the spot, and from my experience, I would say it's probably key, seeing as we know what we know.
Mm.
I would think that there is justification to start sooner rather than later, because the idea of prevention and preventative treatments, as it were, Is advocated within reason. I'm not saying that we treat things that aren't there necessarily or weighed in a younger patient group where there may not be that tangible need to do so. But seeing as we seem to understand what's happening and it seems to be fairly predictable and linear across a variety of doses, then I would argue it does seem logical to start, even if it's a form of topical, LED, something fairly entry level, some radio frequency, perhaps sooner rather than later, before I guess patients or, individuals on these therapies are sort of, acutely concerned with visible signs of laxity, deflation, as it were, the Ozempic phase, which is kind of the more like sort of how it's been regarded more socially. So I
Yeah.
would advocate probably sooner rather than later.
Okay, thank you. And we've got a question from an audience member here. Where do you feel biostimulators like Sculptra and Radius?
Mm.
Um,
Where do they fit into the treatment for these? Was that the
mm,
question, Chloe? I
yeah,
would wholeheartedly recommend them because I think the great thing with that type of drug class, so that type of treatment is that we're not just treating the structural concern, but you're also seeing that incredible improvement in tissue quality and almost the regenerative benefit. They to my mind and in my understandings there is a dual benefit, which is why I used to biostimulate in that particular case study of that lady where we took a very layered approach because there was so much to treat. So I would wholeheartedly recommend. And again, not to say that one biostimulator is better than the other in that class. Again, we're spoilt for choice. There's some really high quality biostimulators. Gone are the days where we only have the options of one. There are
yeah,
some really exciting technologies just within that category coming to market. So we have a choice, but I wholeheartedly support, and I think they're an important part of the overall picture.
yeah, yeah. They definitely fit in a treatment plan.
Absolutely.
And what about lifestyle, nutrition, that kind of thing? How do you go about getting patients on board with following a good nutrition plan alongside these treatments?
Well, I mean, we spend a lot of time at the bedside with our patients, a lot of time, not just the initial consultation, but, they we give them a lot of time and counsel and education. And we have historically always engaged in these conversations if patients are willing and receptive to hear it.
Yeah,
But we've always tried to bring in some form of advice around this to bring out the best of any treatment outcome, to try and reduce any visible signs of systemic inflammation. All we've done really, Chloe, is just build on that and almost take the conversation sort of more down the protein route, talk
yeah,
about certain lifestyle choices we are mentioning around sort of, the weights and that kind of exercise, certain tweaks, if you like, and modifications to just ensure that they're trying to get as much, how can I say, much, not just oral protein, but as much as they can to boost and regenerate that protein is
yeah,
key. But I think there's a place for that probably in most people. Weight bearing exercise and, building core strength is a key, is key exercise for ladies, particularly sort of menopausal age and beyond. So it's not to say that we're necessarily doing anything radically different or having a whole new dialogue of conversation. I suppose we're just kind of embellishing it and saying, there are these other important things to consider, just doing the exercise, high protein based diet, because there is a lot of evidence to justify protein in our diet anyway. I think it's really just a case of us underscoring that and taking the time to really ensure that patients understand the importance of that.
yeah, absolutely. Okay, thank you. And are you noticing any mistakes that clinicians are currently making when treating GLP-1 patients? And what would you say to fix those?
I'll be controversial then, if I
Mhm.
may. I mentioned a few times this evening scope of competence,
Yeah.
something very close to my heart.
Hmm.
And the reason why we haven't decided to go down this route as a clinic to provide these treatments is that I don't feel that we have the right level of knowledge and skill to do so. That's not to say that we wouldn't in future. I feel we have a good understanding and work within our remit to treat the signs and symptoms that we recognize that are associated with this drug class. But we have an MDT approach within our team. We've invested huge time, energy, and effort in building collegial relationships with allied healthcare professionals in East Grinstead. and local hospital. We have the McKindo Centre there, so we are spoilt for choice in terms of the calibre of the healthcare professionals we've got on our doorstep, and we help each other. And I think what that's done for me is just really reinforce the level of respect that I have for seeing how people's bodies change on these therapies. And my good friend, and she won't mind me mentioning her, Lou Somaru, who runs Cosmex Clinic in Cambridge, is highly expert in this area and runs an exemplary weight loss clinic and service that she presented at ACE and gave an overview of her business model. And what will always stay in my mind in terms of what Lou said, because she was asked a very similar question from the audience. She said, do you know what? She said, this jab, this treatment is one element of this patient's journey. She said, do you know how many other allied healthcare professionals should be involved in terms of the care of that patient? She said, I see my weight loss patients every week and titrate the dose, check their bloods. They're
Yeah.
offered cognitive behavioral therapy, nutrition support, exercise, counselling. She said there is a whole wheel, like a cohesive wheel of healthcare professionals. She said, Anna, I'm telling you, the injection is only one part of it. And it really stuck with me. And I thought, she's right though, but it is how it should be done. So to bring that back to your question, Chloe, I feel the danger could be that everything is hanging on the treatment itself rather than all of these other critical facets, because it's the journey beyond that. It's like titrating down those longer term lifestyle changes, longer term changes for skin health. What are patients meant to do then, and who are they meant to turn to if they've only ever been counseled about the injection, right?
Exactly.
Little bit controversial, but that's what I believe. It's not within my scope of competence. I don't have that level of training. It's not
Mhm.
my professional background, so I don't feel it would be. I don't feel it would be right. So I'd say to patients and practitioners, you stay in your lane,
Yeah.
and I think this drug class needs to be treated with a lot of respect. I really do.
Absolutely. I think that's a really great way to end this evening's webinar. So thank you everyone so much for joining. If you're interested in attending more, then go to our website, head to the e-learning section. We've got lots more webinars coming up. Next, I believe we've got imaging devices, and then we've got a series all about genetics throughout July, and as well as like pre-treatment things that we can do to prep the skin. So have a look there. We've also got Ramsey, our conference, taking place November the 7th. So early bird tickets are available, only 125 plus VAT at the moment. So go online, book those tickets. And thank you, Anna. Thank you so much for
Thank
joining.
you.
It's lovely to see you. And we'll speak to you all soon.
Thank you very much, guys. Have a good evening, everybody. Thank
Yeah.
you.